Welcome to Health System CIO's interview with Dr. Jeff Tully, co-director at the Center for Healthcare Cybersecurity and associate clinical professor of anesthesiology with UC San Diego Health. I'm Anthony Guerra, founder and editor-in-chief. Dr. Tully, thanks for joining me today.
My pleasure, Anthony. It's great to be with you.
All right, very good. Jeff, you want to start off by telling me a little bit about your organization and your role?
Absolutely. So, here at the Center for Healthcare Cybersecurity at UC San Diego, we are building and are fortunate to work with really a multidisciplinary team of clinicians, computer scientists, public policy experts, public health experts to study and understand healthcare cybersecurity issues really from the perspective of patient safety. So, in my day job, I'm an anesthesiologist. I take care of patients in the operating room. We use, many different clinical systems, technologies, platforms to provide that care, along with the care for other really important time-sensitive medical conditions like heart attack, stroke, or sepsis. And we know based on some of our previous research, as well as just kind of the general milieu that we've been living in for the past, 10 years or so, that large-scale technology failures, cybersecurity incidents like ransomware, other types of disruptions can really impact our ability to rely on those systems and thus to take care of our patients. So here at the Center for Healthcare Cybersecurity, we conduct sort of data-driven, evidence-based research into some of these topics. We work with industry partners to collaborate on things like designing more secure medical devices and understanding ways in which patients, interpret cybersecurity information, and then have the opportunity as well to kind of work with some of the other stakeholders at a more national level, discussing things like policy and nonpartisan advocacy.
All right, excellent. Very good. So you did a study, you produced a paper from a study, patient care technology disruptions associated with the strike outage. So very specific there. Tell me about the report. But first off, obviously it was a major incident. What were some of the reasons that you picked that incident to study?
Yeah, and Anthony, if it's okay, maybe I can just back up a little bit
Yeah.
and give some context with a couple of other studies that we published. So, as most folks are probably aware, there's not a whole lot of data regarding patient care outcomes in the setting of something like a ransomware attack, right? So, a ransomware attack oftentimes will result in different degrees of network downtime for periods that can last weeks or months. And obviously, as doctors, we kind of had the foundational hypothesis that that type of disruption is not good for doctors and nurses taking care of patients. But we didn't really have a lot of data to sort of back that up or to be able to demonstrate with discrete episodes why that's actually the case. And I think it's important when working in this domain that you want to try to steer clear of fear, uncertainty, and doubt. You want to avoid kind of making any big proclamations without having that type of data to back up your hypotheses. And so our work has been really focused on, are there ways which we can empirically study and measure, patient safety impacts arising from these types of situations? So back in 2023, we published one of the first reports on patient care outcomes associated with ransomware. Now, it's actually quite challenging to study this question because, number one, hospitals who are experiencing downtime due to something like a ransomware attack aren't super friendly or inclined to talk to some random researchers who show up looking to get data on a potentially, sort of devastating situation that can have class action liability prospects, federal regulatory implications. And so sometimes it can be challenging just to get the data to analyze, but also secondarily, it's really hard to measure a lot of patient safety outcomes during network downtime when many of the platforms and tools that you use to do that are themselves dependent on the network, right? So it's hard to sometimes pull a lot of data about patient care because that data is not there because your electronic health record isn't working or your, you know, different quality improvement systems may be secondarily offline. And so, what we did in this paper in 2023, which kind of first kicked off this journey, was we took a look at a healthcare delivery organization that was adjacent to a hospital system that had been hit by ransomware. And so we were monitoring and gathering data while patients were being transferred from the affected system into this system. And we looked particularly at the emergency department. So we saw significant increases in the census of the emergency room. Patients were waiting longer to be seen. More patients left without being seen than compared to normal periods. And we saw in the entire regional area a very significant spike in the number of what's called EMS diversion hours. So when a hospital goes on to diversion, they can't accept any transfers from ambulances or helicopters. That gets correlated at the county or regional level. And we saw that in this local area, again, a couple of systems operating normally, one system hit by ransomware, that EMS diversion hours spiked to a peak higher than even that seen during the pandemic. So it was this paper that really got us thinking about, what how do we think about things like cybersecurity incidents in a more regional sense? These are like public health disruptions, like the impacts at one center ripple out to even hospitals that are not themselves affected by the cybersecurity incident. So this kind of got us into this mentality of thinking about cybersecurity in the same way that you might think about natural disasters or mass casualty events, insofar as it's the weakest link in the regional chain. If that gets disrupted, you see those ripple and cascading effects elsewhere. And so a lot of our work has been, is there a way for us to more accurately kind of monitor, gather data, understand the potential for regional and health system specific impacts from these types of events? And so for the past 2 years, we've been working on a project that's been sponsored by the Advanced Research Projects Agency for Health, or ARPA-H. And that project is called the Healthcare Ransomware Resiliency and Response Program. And one of the aims of that work has been to develop ways in which stakeholders can start to have more information as to what's going on throughout the national critical health infrastructure from a sort of digital standpoint. And so we have built this system that, working with folks here at UC San Diego, we're very lucky to have collaborators like Dr. Stefan Savage and Dr. Jeff Volker in the Department of Computer Science and Engineering. And these gentlemen are experts in this kind of field of empiric internet measurement. So are there ways in which we can understand the infrastructure of the internet, monitor it in real time, derive data about things like availability and downtime based on some of the signals that we see in the space of that type of monitoring. So long story short, we have done the work to sort of build out a system that is able to in near real time kind of surveil thousands of hospitals across the US, because we have taken the time to sort of map out where they live in cyberspace and their associated domains and IPs. And it just so happened that as we had set this platform up and we were recording data, July 19th of last year, there was a widespread technology failure as a result of a faulty software update that was pushed out by a cybersecurity company. So that was sort of this case of what we call, opportunistic failure, insofar as it gave us a chance to kind of assess what happened. We weren't looking for this, we weren't anticipating this, but because we had set up this system that was monitoring these hospitals and their network availabilities, we did see effects of this large scale outage. I know that's a lot, so I'll stop there, Anthony, to see if you have any other clarifying questions.
Yeah, so it's interesting. You sort of were monitoring um, a certain number of health systems across the country, and when did you realize after the fact that this is something, we could go back and look at? Because the incident happened, it was a big deal, and then at some point you said, "Hey, wait a minute. We've got data on this whole how this whole thing went down, so let's take a look at it." So tell me a little bit about that sort of evolution of how that happened.
It was pretty quick, Anthony, because
Yeah,
as you well know, there were contemporaneous media accounts about all the different sectors that were being affected by this event,
yeah.
including healthcare. And so, given the fact that we had already seen some initial proof of concept events from other ransomware attacks prior to this episode, we knew that this system, while not perfect, was approaching a degree of sensitivity and specificity where we could see these types of disruptions. And then very quickly, we went back and said, oh, yeah, actually, across many of the different signals that we're looking at, namely things like IPs specific to the hospital, but also fire endpoints, we were able to see outages that corresponded seemingly with the time that this update was pushed out.
So this is an ongoing monitoring that you have in place for, I don't know how you would describe it, many health systems, all health systems. It's some sort of window onto this stuff that you have going continually.
Yeah, so it's an idea that has sprung more from this larger established body of empiric internet measurement, which is
Hmm.
that if you sort of are aware of different domains and have basic network scanning approaches where you can monitor availability and you are able to map and categorize different domains and IPs to health systems through a variety of techniques, you can start to have a little bit more visibility into things that I think previously we just kind of wrote off, even at high levels of various stakeholders. It's impossible to measure this. It's really challenging. It's such a vast collection of networks and entities. I don't think that anybody really ever thought about approaching a problem like this from the perspective of, well, maybe applying some of these types of techniques, we can at least get some degree of signal. And I think it's important to caveat here, this is a technique and an approach and a system that is continuously being worked on and iterated. There's, sensitivity and specificity with respect to things like false positives, false negatives. I don't think any of us on this paper would ever claim that we have ground truth, but what we're looking for is signals, right? We're looking for data. We have a hypothesis that in a large scale technology outage like this, we see this disruption, and with all these networks being disrupted, there's an assumption that may have some type of effect on the direct patient facing tools and techniques that are dependent on these networks and endpoints. And so we have data that is definitely correlative, not necessarily causative, but enough to get
Hmm.
us to be able to ask questions and to suggest to the larger community that these types of processes and systems are worth further study and empiric data and ways that which we can start to piece together information that we can then use to solve challenges.
So is what you've put together, and I'm trying to, get my mind around what it could be used for. Is it something that could evolve into a centralized service, almost either privately run or government run, some sort of monitoring early warning system that can be used to help health systems? Or is it something like a model of monitoring that once you get it more refined, you could say, hey, like an open source, hey, everybody should be doing this for your own health systems. Do you ever have a case where a health system suffers some sort of outage and they reach out to you down the road and say, "Hey, do you have any information on what happened to us?" I mean, is that where we're going with what you've done?
Couple of great questions in this. Let me kind of break it up just a little bit. I think we do envision this as a way to, in sort of very simple layman's terms, and I want to make the caveat that I am just a humble country trauma anesthesiologist, and it is my technical computer science colleagues that are really driving sort of the frontier science here. But we do think of this as a way to sort of monitor the digital vital signs, so to speak, of national critical infrastructure for things exactly like you mentioned, early warning purposes or understanding, hey, a system in one part of this region may be impacted, and therefore the other healthcare delivery organizations may need to prepare for the types of surges that we've seen in some of our earlier work. And then I can allude to this a little bit, or we could talk about it, but some of the other projects that we have going on at the center is really about how do you respond to these types of attacks from a clinical perspective. So how do doctors and nurses take care of patients during extended downtime? Are there technology platforms that we can bring in to help restore some of the basic functionality while there's more of a formal incident response IT perspective style of work going on? So we kind of see these types of efforts as synergistic. We can't do anything until we know and are monitoring and collecting data on the overall infrastructure, right? And so in the same way that you have kind of like early warning systems for hurricanes or
Hmm.
or earthquakes, having something similar or analogous to that from a public health standpoint, that helps kind of provide that foundational data that we can then use to monitor. We can, retrospectively go back and look at things like, how for larger health systems, do we see certain hospitals go down quicker? I mean, I should also caveat that this type of system, which essentially is scanning for the availability of publicly facing, internet endpoints, we are never going to know information about something like a ransomware attack before the hospital itself knows that, right? The
Hmm.
hospital that is affected by ransomware knows that, and the signal that we are measuring are some of the mitigations that they are taking, like shutting down their networks, right? So this is less about telling the hospital something that they don't already know and doing exactly what you mentioned, which is kind of this early warning for larger stakeholders or responders, different parts of the government who are interested in knowing about these things and marshaling resources and help. So I just want to contextualize that.
Yeah,
That's
of
kind of how
course.
we look at it.
Yeah, so one of the other interesting sort of divisions here and how you look at things is we've talked a lot about cyber events. We've talked a lot about
Mhm.
ransomware, but the event in question here was not a cyber event, was not a
Exactly.
ransomware event. So there may be commonalities at a certain level or in certain
Yep.
ways, commonalities, and certainly there will be differences in how these are treated in terms of obviously you've got law enforcement issues.
Yep.
Do we pay? Don't we pay?
Yep.
Um, but I guess in another sense, if you're down, you're down.
Yep.
And maybe to some degree, when we talk about the patient care element, that
Yep.
doesn't matter. We're just assuming a
Yeah.
scenario where a system's not available.
I think the way that we look at it is under this larger grouping of technology failures. And that can be any number of situations like a cybersecurity incident, like a software bug or error, or somebody accidentally cuts your fiber cable, right? So there are a number of ways in which the systems that support, again, sort of the thing that I focus on when I'm in the hospital, doctors and nurses taking care of patients using these tools and technologies, that type of disruption can come from a number of directions. And so I think it's helpful to look at it. And again, for this particular paper in this particular instance, we were not looking for this, right? This just happened as a sort of opportunistic failure that we then caught on our system that we had intended to monitor for things like ransomware induced outages. So I think you're
Yeah.
very right in making that point.
So let's talk a little bit more about, one of the huge issues here is duration of outage. I mean, that makes all the difference in the world, right? A quick outage, an hour, a couple hours, there's a lot of things, that are just kind of a blip on the radar. It used to be sort of everyone go get coffee and IT,
Yeah,
they'll have this up in a few minutes. Then
yeah,
we've seen ransomware incidents where, as you're talking about, days, weeks, or months, and that blows everybody's plans out of the water. And that's what people say. They say, we're good 48 hours, like, but forget it. Over a
yeah,
week, 2 weeks, like,
yeah,
we're in an area that almost you can't plan for. So you've got that kind of a thing about duration, and then I'd like to talk more about patient care,
yeah,
and things you can do and work around, and things you can't do, and that's when we divert patients somewhere else because we can no
right,
longer practice in a way that we are pleased with. So, it's weighing these risks. It's like
right,
we don't want to send someone a half hour away, but we
right,
have to weigh the level of care that we've been reduced to here because of this situation. And there's so many nuances and factors here. You can get very patient
100%,
specific, right? You could say,
100%.
well, we could deal with patient X based on the current systems that are out, but we can't deal with patient Y. So it really
Exactly.
gets complicated. Your thoughts?
So much to unpack there. I would say I agree with that overall framing, with one potential exception. I think you said, and I don't mean to misquote you, but earlier, short downtime's not a problem.
Hmm.
I would say that there are certain situations, very time-sensitive conditions like stroke, heart attack, sepsis, trauma, in which even short durations of downtime can be a problem. And in a situation like the one described in the paper, where you have a widespread outage that affects hundreds of different hospitals, I do think that has the potential to be a significant public health impact, right?
Hmm.
Hundreds of hospitals, even for very short periods of time, the aggregate of that is something that I think we should try to prevent. I love that you hit on the specificity of sort of the clinical scenarios, because I 100% agree with that, and I think that that is something that to date has been missing in traditional sort of cybersecurity response in healthcare. Um, because really no two patient populations are alike. And so our center has focused on that particular problem. So one of the other things that we're doing in the context of this ARPA-H work is we are putting together clinically oriented downtime procedures that are specific to certain specialties and even subspecialties. So a playbook for how a cardiologist should handle prolonged downtime is going to be very different than how a hematology oncology doctor will handle it, different than how a surgeon or an anesthesiologist like me would handle it. We are starting to put together some of those resources that very soon are going to be available as open source tools so that hospitals can start to adjust and orient their downtime procedures. I don't want to speak about any particular hospital, but I will just say, having been in medicine for 10 to 15 years across a number of institutions, I know that our downtime procedures, generally speaking, have a lot of work to do to kind of accommodate that length that you mentioned. It's about It's currently about, how do we weather an EHR, an electronic health record update for a couple of hours in the middle of the night on a Sunday, right? But we don't have what do you do when you are 1 week into this, 2 weeks into this, 4 weeks into this with no end in sight, and you're starting to run out of your clinical supplies, you're starting to have issues with tracking longitudinal patient information. How do you kind of put together a response for that? And sometimes the answer may be as simple as you are not able to take care of those stroke or heart attack patients. And so you do need to start transferring right away. But in some situation, especially in one of these situations that we're very concerned about where there is widespread outages and you may not be able to transfer. If you are there's a single level one trauma center in New Mexico. If you're not able to transfer to the hospital next door that's unaffected, what do you do about that? How do you kind of triage and take care of those patients? So that is a very big problem that we are doing a little bit of work on, and we'll hopefully be able to make that a little bit better. I know that's a lot there.
Yeah, so as we talk through this, I mean, and I've sort of thought this stuff before, but I just had the thought that there are so many variables and nuances and different patient conditions, different specialties, different
Yep.
scenarios for outages, cyber, non-cyber,
Yep.
affected systems here, affected systems of the possible healthcare organization we would divert to.
Right.
Meaning sometimes there's no point in diverting because they're in trouble too, and
Right.
you've got a stroke victim with a certain amount of time, and diverting them
Yep.
over there is going to be worse than keeping them here.
Correct.
You've got a billion things. So what that makes
Yep.
me think of is that planning for scenarios is very difficult in that situation because there's a zillion of them. But one way to go about it is to focus more on governance and flexibility in the moment based on the situation. So if you get the right people in the room, given any of these things, if you get the right people in the room and you have dynamic leadership and you have good information collection and communication, you're going to have you need so much flexibility in the moment that's kind of important to focus on that area, maybe as well as scenarios. But what do you think?
I mean, Anthony, are you looking for a job? Would you like to come work with us? Because you are hitting the framework that we are using to approach this, which is adopted from and inspired by the fields of emergency management, business continuity. There is a hospital incident command system framework that is put in place for disasters like earthquakes, like hurricanes, like mass casualties that need some modification in the setting of downtime. Downtime, secondary to something like a ransomware attack, is a very unique beast, right?
Yeah.
Both in its duration and many of the same implications that you realize. But there are tools that we have previously used in different types of disaster management that I think can be adopted, and we are adopting to use that perspective when we think about these problems. I think the main thing that I would convey to a CIO or a CISO audience is silos are not helpful in this process, and you need to be working very closely with the clinical arm, the folks who are on the ground
Yes.
taking care of patients, your emergency managers, your business continuity managers. We can't think of this as a solely IT based problem anymore. And that all we need to do is get Mandy in here to help, restore our networks and endpoints. We really need to be communicating bidirectionally between the folks that are dealing with the situation on the ground while we think about the overarching technology considerations.
Totally agree. And I would say it's even more than bidirectional because in different scenarios, you've got a lot of people at the table that want to have a say, and someone's got to run the show. And I
Yeah.
would think it would be the CEO, but I'm not sure. I mean, if I was a CEO, it'd be really tough for me to pass this off to someone because, as you said, someone has to be running the show. They have to hear from the CISO about what's going on and what's affected, what's got to be taken offline, what can come up. The CIO is going to have a larger picture of the technology. You've got leaders of clinical specialties, as you mentioned, they're all different. They're going to have patients of different acuity in different situations. They're going to have patients that are in the hospital. They're going to have patients that are coming into the hospital. So you've got a lot of stuff going on there. You may have the FBI at the table. You may have your cyber insurance company at the table. You're going to have a lot of voices there. And so you need to have real time discussions, pulling in all these points of view to figure out what we're going to do. And things are going to change by the hour, and your decisions may change by the hour. So you need to put all these things in, and it's complex, and someone's got to run it.
Yeah. 100% agree. I think there is a traditional framework here where you have an incident commander. We've introduced this new role that we're calling kind of a ransomware resiliency specialist who works at the side of that incident commander to triage some of these other considerations. What our resources that hopefully if we were to be talking in a couple of months, are starting to come out in a publicly available open source fashion. What we're hoping to do is give people a foundation to be thinking about prolonged downtime, to help them with some of the early considerations, things like how are you going to communicate? Do you rely on a lot of VoIP systems that are not going to be accessible? Do you
Right.
have a list of cell phones? Do you have a staff schedule that is manual, not on an email Outlook, platform somewhere? We want to kind of do some of the basic work so that they can think about the unique considerations because again, every single incident is going to be different. Every
Mm.
organization is different. So if we can help push people, 70, 80% of the way there with
Yeah.
respect to a ransomware specific downtime contingency and playbook, then I think we're doing a lot to be able to improve um, the margins.
Yeah, and it's interesting, it would be interesting to hear from the clinicians in this sort of real-time environment or even ahead of
Hmm.
time. You could send questionnaires to your head clinicians
Yep.
and say, you know, you give them different scenarios. So
Yep.
you can't use system X. What's the
Yep.
implication for here? Now,
That's
for
exactly what we're
example,
doing right now. Yeah.
when
That's
and I want to hear about it, but
yeah.
what real quick, when I think of imaging, right? So for example, if an imaging modality isn't functioning because of some kind of outage, we can't do imaging. So we
Yeah.
may be done here, right?
Yep.
And but if it's the modality's working, we could get the image, we could see the image on that modality. The radiologist may have to go there, which is slightly
Yep.
inconvenient, but not impossible. So
Yep.
the packs may be out, meaning he can't see it at
Yep.
home or somewhere else, but the modality's working. That's different than the modality not working.
100%. That's exactly right.
So, I mean, what do you see? You mentioned you were doing that kind of questionnaire thing or getting some
Yeah.
information from clinicians about different scenarios and how
Yep.
they might function in different scenarios with lack of
Yep.
access to different applications.
And that's a great example, and I think that is a situation where in just going through the mental model of that and understanding the workflow, that takes a lot of cognitive load off of somebody in the moment dealing with
Yeah,
this acutely, right? There's a checklist, is the actual modality down? Oftentimes, most of the time, it's probably not going to be, right?
right,
Unless that
right,
unit is directly infected by something,
right.
it's probably not going to be down. You will just lose the connectivity that allows you to push those results. And so you do probably need to station a frontline radiologist who will sit at the CT scanner and look at the images and then using a walkie-talkie or a cell phone relay that information to whoever needs to know, right? So just kind of asking some of these basic questions removes that discovery or fact-finding obligation from people responding in the moment that hopefully lets them free up to think about the more subtle aspects in which their response may need to be tailored for whatever service lines they're focused on, the patient populations. And we've done a lot of work looking at previous incidents to understand what are those patients that are most at risk. We're going to be doing some publications to that effect very soon too, to kind of
Mhm.
give people an example. What are some basic questions that you need to ask? What are the patient populations that are most at risk? And if we do that discovery for you initially, that frees you up to really get into the nitty-gritty details that are going to be what save people's lives.
Very good. One of the interesting dynamics here that I've found is, so if you look at the evolution of some of this stuff, it's we put in these systems and they make patient care better. They improve patient care.
Yep.
I believe that. I think everybody
Yep.
believes that.
Yep.
Then we get in this weird phase a few years ago where we started to have incidents impacting the availability of these systems, but organizations were so afraid of impact of describing any negative impact that we'd see press releases all the time that say we had an outage, but
Right.
everything's great. There's no
Right.
problem. No patient care has not been impacted.
Right.
We're beyond that silly kind of reactionary marketing and to the
Yeah.
reality of if we know these systems make patient care better and safer, when we lose access to them, we can't just say it's all great, there's no impact, because then what was
Yeah.
the point of having them in the first place? So, in order to address the outages and deal with this impact, we have to admit we have a problem, as they say
Right.
in certain programs, and that's
Right.
where the industry is getting to now. But that still doesn't mean if you've had the outage as a health system, you want to run around talking about patient impact. So we've got this weird dynamic here.
Yeah, and it's really hard to I don't ever speak about an individual institution. I don't fault anybody for how they approach these problems. There but for the grace of God go
Yeah.
we. And there are a number of other considerations, right? There are regulatory issues, there are class action lawsuits. Like it's I think we're making it too simplistic if we just pretend that this framework or mindset is one that is purposefully obfuscating the problem. So I have a lot of sympathy for organizations. I will say I talk about institutions that do a great job of being
Mhm.
transparent and open. So University of Vermont, from the
Mm.
C-suite on down, and their doctors have been awesome going to conferences, sharing their experiences, publishing in the literature. And so I do think that just being able to be a little bit more transparent, even if it is only within other health systems or academicians, like that is a step in the right direction. We don't get too much into the policy weeds on purpose, but I think that you can start to look at some of the initiatives that have been proposed by organizations like the Health Sector Coordinating Council, cybersecurity performance goals, best practices, frameworks, and you can start to envision a world in which we're starting to integrate some of these cybersecurity controls or frameworks within to other accreditation platforms in ways that maybe someday we can talk about a situation in which if a hospital has done everything right insofar as meeting these minimum standards,
Mhm.
doing certain controls, doing everything they can to reduce their risk, and they still get hit because we know that these attacks are becoming more sophisticated, more complex. We have, advanced persistent threats at a very high level that are starting to target some of this infrastructure. If you are doing the best you can with the limited resources you can and you still get hit, maybe there are types of safe harbor provisions or things in which you'd feel a little bit less reluctant to share that information because the potential penalties would be a little bit less. But that's kind of blue sky thinking on that end.
All right, Jeff. I'm just going to give you anything else. Give you a final opportunity. Again, we try and, as you do, help people. So I would say you're a clinician, so any piece of advice around that patient care, everyone doesn't want that impacted. Wants to do the best they can for their patients. You lose these tools that are the lifeblood of your practice.
Yeah,
How you practice the art of medicine and the
yeah,
science of it every day. That's a tough position.
yeah,
It's hard to prepare for that because clinicians are so busy, right?
yep,
It's like I'm busy every day, all day with these systems. And by the way, the whole industry and health systems and CIOs, all these discussions I have, a huge focus is training. We need to
yep,
train better on the apps. We need to
yep,
get them more trained and help people and at the elbow
yep,
support. So it's all about using these tools better, and yet we still have to plan for working without them. So
yep.
what are your thoughts there?
I would just say, kind of wrapping up, I would encourage curiosity amongst the CIOs and the CISOs to engage with clinician colleagues, to bring them into some of the considerations or discussions, particularly around resiliency and downtime planning, to start to build some of these bridges that I think ultimately will give us the best chance at minimizing the impact. Fortunately, these types of incidents show no sign of abating.
Mm.
I think about it as a matter of when and not if, and so there's a lot of important work to do on the standpoint of prevention. There's a lot of resources that we can invest in to try to reduce the risk of something like this happening. But I think we need to spend more time and focus on understanding how we can best protect the patients who may be impacted in the setting of a technology failure like this. And that only comes from working closely with clinicians. And while I will say we're all busy and we hate to get the mandatory trainings for this
Yeah.
or that. If you come from a good faith standpoint of saying, hey, I would really like to understand the dependencies that you have, the ways in which you rely on these programs or platforms or networks throughout the course of your day taking care of patients. Have you ever thought about what would happen if you didn't have access to them? How can we plan together to make
Perfect.
sure that doesn't happen?
I think that's brilliant. Building bridges to the clinicians. So, Jeff, I want to thank you so much for your time today, and I hope we can reach out to you down the road and hear from you again.
Absolutely, Anthony. Thanks so
All right.
much.
Have a wonderful day.